penetration is also reduced by the retraction of soft tissue such that the mucosa is taut. With all the mandibular techniques, it is preferable to use a 25 gauge long needle. The 25 gauge is preferable to the narrower gauges for two reasons. You cannot differentiate among the 25, 27, or 30 gauge, so there is no advantage in using the narrower gauges. This space is bounded laterally by the ramus of the mandible, medially and inferiorly by the medial pterygoid muscle, superiorly by the lateral pterygoid muscle, posteriorly by the parotid gland, and anteriorly by the thin buccinator muscle. This anatomical space contains the inferior alveolar nerve as well as the lingual nerve, which is usually also anesthetized by these techniques. It also contains the inferior alveolar artery and vein and the sphenomandibular ligament. Accessory innervation may originate from several sources. The inferior alveolar nerve may give off branches anywhere following its exit from foramen ovale. These accessory branches can enter the mandibular canal through any of the foramina on the medial aspect of the ramus, usually near the coronoid process. This particular route often innervates the second and third molars. Other sources are branches which travel with the nerve to mylohyoid, which often innervate the teeth anterior to the molars. It has been proposed that accessory innervation to the third molar may originate from a branch of the auriculotemporal nerve, which enters a foramen near the neck of the condyle. Branches may accompany the lingual or buccal nerves, and the routine blockade of these nerves should result in profound anesthesia. How is residual sensation due to accessory innervation treated? The key is to deposit local anesthetic such that it lies proximal to where the accessory branch rejoins the main trunk of the mandibular branch of the trigeminal nerve. This means that techniques which bring the anesthetic more superior or deeper should be more successful. This may be the explanation as to why the alternative techniques, namely the Gao-Gates or Akinosi, have been reported to have high success rates. On occasion, accessory innervation may also be anesthetized by administering the local anesthetic adjacent to the tooth. This may be accomplished by administration of either a paraperiosteal, a periodontal ligament, or an intraosseous type of injection.